I have to cut down this talk already lah because it takes some time already. Hold on. All right. So back to here. Okay. So endemic is the video blocking. Is our video the video blocking my slides? Is it blocking?
No.
No.
All right. Okay. Okay. So epidemic. When you look at this, the picture of the world here. It refers to a sudden increase in a particular disease in a specific geographical area. So, right. So for example, all these yellow dots, they represent a high number of cases, but they're all localized in a particular country. All right. Pandemic, for example. So, like for example, in 1899, we had a new case of cholera in India. So that means there was a lot of cases of cholera just in a particular area, and it claimed more than 800,000 lives, 800,000 lives. Okay, and then we can also look at epidemic in the modern sense. So countries where they have 4 seasons, they will have some cases of flu during spring, autumn, but when it comes to winter, there'll be a sudden peak in cases. So that is also called, known as an epidemic. And coming to pandemic, it means there's a lot of disease, same disease case that spreads around the whole world. A huge number of people will be affected. Examples in the past, 1981, when HIV first emerged, at that time there's no HIV treatment. So the infection spread worldwide and claimed more than 36 million lives. Same thing for 1918, the famous Spanish flu pandemic. And then in March 2020, WHO declared that COVID-19 is a pandemic. But now we are entering into COVID-19 endemic, not pandemic. So what is endemic? Endemic is when the disease is constantly present in a certain country, but at a low spread. So for example, dengue fever is endemic in Malaysia. So whatever we do, we can never get rid of dengue. Somehow it's just always in our country. But the spread is low. And then malaria is endemic in Africa. So which is why if you're a traveler going into Africa, you have to take preventative medication to prevent malaria before you enter the country. So really what we hope for in any pandemic is to eliminate the organism completely, like what we've done with smallpox, which was eradicated in 1980. But when you have a virus which is as virulent as COVID-19, coronavirus, what is more likely is that the pandemic will shift into endemic status. So which route would we prefer? New Zealand, if you see this graph here, this is a number of daily new confirmed cases of COVID-19. And New Zealand, you can see, is as close as zero. I can say zero. So 0 new cases every day. So that's what they are aiming for. So New Zealand pursued elimination strategy. They're very adamant to keep their COVID-19 infections close to 0. But it would be at the expense of heavy travel restrictions. They're very strict with their borders. Snap lockdowns, which means impromptu lockdowns whenever outbreaks occur, and very strict contact tracing. But how long would that go on? UK, on the other hand, has taken the endemic route. So they say that they've accepted to live with the virus, and for them, a low rate of severe disease and death would be considered tolerable. So whenever a country declares the move from pandemic to endemic, it is saying that we're going to accept the fact that the virus will always be present in the country. However, unlike pandemic, the spread is going to be low, only occasional outbreaks, which means that we're going to be able to manage the disease. For a country to be in endemic state, the majority of population has to be vaccinated. If the person or if a few people are infected, it will be mostly mild symptoms like the common cold. There'll be low number of severe illnesses, hospitalization and death, reduced strain on the health sector, and all this will happen despite relaxation. So although there's going to be reduced MCO, reduced lockdowns, so on and so forth, we will not see an increase in severe illness, hospitalization, and death. And also regular booster shots may be the way to go to keep us in a manageable state when it comes to COVID-19. But what does that mean for us? It would mean that the restrictions on economy, travel, and socialization will loosen up. Hence, we must be very careful not to slack off, because there's a tendency when we see everyone is walking around, going to cinema, we may think that everything's over, but it's actually not. It's not going to be like the pre-pandemic state that we were in. So we have to make sure that we continue to follow SOPs, maintain a healthy lifestyle, and do regular self-tests for COVID. Okay, so coming to my next topic, the COVID-19 booster vaccine. We're going to go a little bit into the coronavirus structure and vaccine technology for our basics. And then we're going to understand how our body's immune system works so that we can answer the question, should everyone receive the booster? And we are also going to talk about mixing vaccines. What's the latest data we have about mixing vaccine brands? So this is a picture of a PCR report that my colleague did recently. My colleague's name is Dr. Amir. We are both stationed at Clinic iMedic. So this patient did a PCR and she was found to be detected. But what I want to draw your attention is to this bottom here. If I zoom that in, you'll see that this is, you can see E gene, ORF, one antibody, N gene. So I always get questions from patients. They're asking me, what exactly are all these letters? What do they mean? So to answer that, I've taken the liberty to draw out the coronavirus structure. The green snake-like structure here is the RNA, which holds the genetic code of the virus. And then surrounding that is something called the nucleocapsid layer. And then the blue layer here is the membrane. Then the outer layer is the envelope, the purple one. And then all these orange projections are the spike structure of the virus. So all those letters actually just represent different parts of the virus, like envelope, nucleocapsid, things like that. This RNA, if you open it up, you can see it's something like this. So whenever our body, the ribosomes in our body, or whenever a PCR lab machine reads a genetic structure, it reads it from one end to the other. So here's the machine. It can't read anything in this part because there's no information. And then when it reaches something called a start codon, it starts to read the information and gathers information about the genetic code of the organism. And it keeps on reading until it reaches a stop codon, and then it stops reading. So this part here is called the open reading frame, which means it is opened for translation. So that's what ORFs mean, that's all. So different countries all around the world, the way they do PCR is by detecting different parts of the virus, and that's about as significant as it gets. So when patients ask me, which one do I look at? Because all these are actually CT values. Which one do I look at? The answer is really not much difference, because the same virus will have the same nucleocapsid, same envelope. So it's not going to be much difference, 13, 14, 16. But to be simple, I always say go for the lowest value. Here's another example. ORF and N is only 17 to 20, so not much difference. The other thing I want to bring to your attention about the coronavirus is that the spike protein, as we know, is the most significant part, because if there's any mutation that occurs on the virus, it occurs on the spike protein. It is also very significant because it is the structure that locks onto our cells, much like a lock and key. So it locks onto our cells and then it engulfs the virus. That's how the virus enters into our cells. So now we talk about the coronavirus vaccines. Now that we understand the structure, we'll understand this better. The Pfizer or Comirnaty vaccine is an mRNA vaccine. So the way mRNA works is they take the genetic sequence that codes only for the spike protein, they put it into a lipid nanoparticle, okay, and then inject it into our body. So that particle, that genetic code enters into our nucleus, into our cytoplasm, and then the ribosomes in our cytoplasm reads the genetic code, and then it obeys the genetic code to produce spike proteins. And then the spike proteins are introduced to our immune system, and our immune system produces the correct response. The AstraZeneca vaccine is a viral vector vaccine. So viral vector means this is a carrier virus. So they've taken chimpanzee adenovirus, and this is how it looks like. The black genetic code belongs to the adenovirus itself. But this orange part here is embedded into this virus's genetic code. And this orange part is the sequence. It basically reads the genetic code for the coronavirus spike protein. So the same thing happens, it's introduced into our cells. Our body, translate it into spike proteins, and then our immune system works to build immunity. Okay, and then the Sinovac vaccine is inactivated killed vaccine, which means they've killed the whole virus, which is why it's black here. and then the whole thing is introduced into our body. It's not just a spike protein. So Pfizer and AZ antibodies are produced to target spike protein, whereas Sinovac antibodies are produced to target multiple parts of the virus. So we'll talk about this later. We just have this basic in our mind first, and then later we talk about which one we should use as a booster vaccine. Okay, so discussion here. First question, we know that mutations happen on the spike protein. Will the current Pfizer and AZ vaccines that were designed to stimulate antibody production towards an older variant spike protein work? Okay, so the question is, our current vaccine was actually designed to produce antibody towards the older variant, but now we have Delta variant. Would this still work as a booster? Okay, so studies currently show that the current vaccines do have protection against the Delta variant. The reason being because the antibodies that we develop towards these vaccines, they can adapt to fit the shape of the new variant's spike protein, because the current variant, the structure is not too different from the original strain. So our antibodies can still, tweak a little bit to fit the shape of this new variant. But it will not work once mutations produce very drastic change in shape. And at that point, we would need variant-specific boosters. Okay, so question, why do we need more than one dose? Why do we need a second dose? And then now, why is there talk about the third booster dose? To understand that, we have to understand how our body's immune system works. So this is where it gets very interesting. This is just an animated picture of the virus with its spike protein. And these Y-shaped structures are how our antibody looks like. So they are actually Y-shaped, and they hook onto the antigen through the open upper part of the Y. And once it hooks on like this, it will neutralize this antigen. That's why they are called neutralizing antibodies. They destroy the antigen. And we'll see how they do that later. Our immune system is broadly divided into the innate immunity and the adaptive immunity. The adaptive immunity is the one that is relevant when it comes to vaccines, but we'll go through what innate immunity is just in a bit. The word innate means to be born with. So this innate immunity we already have since birth, as opposed to the adaptive immunity, we do not have that when we are born. These are the cells that belong to the innate immunity. The notable ones would be this dendritic cells, which looks like a star shape with extra legs, and then the macrophages and the natural killer cells. So these cells, they line our skin. They are present in the inner part of our nose, in the lining of our stomach. They're present in the lining of our urinary system, and they're also present in our tears. So they are our first point of defense. If there's any bacteria or virus come in, they would be the first cells to fight the virus. This is the picture of our respiratory tract, the upper and the lower respiratory tract. If we zoom that in, we can see that, for example, we know this dendritic cell, this is familiar, this is the starfish shaping, and these macrophages, these are cells of the innate immunity. So they are our first point of defense. So if there's even dust or any small virus comes in, this guy would actually eat up the particles so that we are protected from further infection. The innate immunity is not specific, so that means that it would destroy any foreign material that tried to enter the body. So this foreign material can be virus or bacteria or dust, pollen, things like that. So here's a picture of our skin. This is the environment here. And this is the cute little pathogen that's trying to invade this guy's body, but our innate immunity is not specific. As long as you see something that's foreign, it would stop it. And the way it stops it is by engulfing it or producing an inflammation to block it from further infecting our cells. It is not specific, as I said, so it doesn't matter whether it's virus A or bacteria or virus B, it would attack at first look. Before anything, it will attack first. So the innate immunity works immediately. However, they are not strong, so they have very low potency. When they are overworked, they will get help from the adaptive immune system. And unfortunately, they do not have any immune memory. So I will talk about immune memory because it's very important when it comes to vaccinology. Now coming to the the adaptive immunity. So as I said earlier, this is not present since birth. These are immune cells that are formed after each exposure to infection or vaccination. So meaning that's why it's called adaptive, because our body is continuously adapting to upgrade the defense system. So if there's a new virus that comes in, then we'll build new cells of the adaptive immunity. Or if there's a new vaccination, then we build more a new form of antibodies, so on and so forth. These are cells that belong to the adaptive immunity, the B lymphocytes and the T lymphocytes, also known as B cells and T cells. They are very specific. So meaning if you have infection to Salmonella typhi, your body will start to produce B cells and T cells that are very specific to Salmonella typhi. And then in another time, in the future, if you get an infection by another bacteria, say E. coli or Clostridium tetani, the B cells that were produced by your body to fight this guy cannot fight the other guy because they're not specific for these other guys. They're only created to target one specific antigen. They also take time to work. So which means from the time you are infected or exposed to an antigen, be it by either through infection or vaccination, you will only start to build cells of the adaptive immunity at least 4 days. It's usually 4, 5 days later, 7 days later. So it takes time to work. There's a time lag. But when they are produced, they are very strong. So they have high potency. And they also produce something called immune memory. And I'll talk about this in the next slide. So this is a very important picture. If there's anything that we're going to take back, this is the one that we have to take back because a lot of questions can be answered just by looking at this diagram. So this is how our adaptive immunity works. If you have an antigen that enters into the body, be it either a new infection or by vaccination, after minimum of 4 days, your bone marrow will start to produce CD4 T cells. We have many kinds of T cells, but the first one is CD4 T cells. This is very important and just also another nugget of information. For patients who have HIV or AIDS, they are not able to fight any infection because they have very low CD4 cells. So if this first cell is very low, what more the other cells? They can't even produce the other cells of the immunity, adaptive immunity. Okay, so coming back here. So the CD4 T cells will stimulate the production of helper T cells. And then these helper T cells, they stimulate the production of CD8 T cells. And then the endpoint is the production of cytotoxic T cells. These cytotoxic T cells are very, they are effective, or they're very efficient in the sense that, as their name suggests, cyto means cells, toxic means destroy. So they will go about in our bloodstream just wandering about, and then if they see any cells of ours that have been infected by a virus or a bacteria, they will destroy not just the organism, but the whole cell. They will destroy the whole cell. Okay, so cytotoxic T cells. And then the helper T cells, they also do produce B cells, which produce plasma cells, which produce our antibodies. So it's very well known that our antibodies are produced by B cells. The other thing that they produce, these B cells, they also produce memory B cells. Okay, so let me explain what is the purpose of these memory B cells and what exactly is immune memory. Just think of these memory B cells as like a video, like a cameraman, okay, cameraman. So what they do is they would take a video or recording of all the events that's happening here from the time your body is exposed to the antigen. So it records everything that's happening and stores it in its memory disk, so to speak, so that the next time, the second or third time you're exposed to the same antigen, we don't have to wait for this lag here and then all the way here, all the way here. What it does is it will remind the other cells that we have fought this infection before. Okay, so we fought this enemy before, guys, remember? So it will produce the recording back again to the other cells. And when it does this, it creates a shortcut. So it straight away stimulates the B cells to produce plasma cells to produce antibodies. So this way, it is a shorter cut as opposed to like this. Okay, so that is the purpose of the immune memory. So that the third, second, third, fourth time you're exposed, you will be able to produce a much faster kind of reaction, so to speak. Well, not faster, but a more effective reaction. Okay, so discussion. So why do I need more than one dose of vaccine? Before I answer that question, I want us to look at this graph. This is also a very important graph that I want all of us to remember and take back. So on this x-axis, this x-axis represents time. So weeks after exposure to antigen. So just say you're going to be exposed to an antigen here, and then this will be 1 week later, 2 weeks later, 3 weeks later, so on and so forth. This y-axis represents the level of antibodies in our serum. So if it's somewhere here, you have low antibodies. If it's here, you have high antibodies. So if just say you're exposed to the antigen here, remember that time lag that I told you about is at least about 4 to 5 days before your adaptive immunity starts to produce B cells, T cells. And then it starts to produce the antibodies, the level goes up, and then it goes into something called a contraction phase. So the levels go down a little bit. But the second time you're exposed to antigen, you'll start to produce even more antibodies, much higher. So there are two things that you can see in this graph. Why is it that, number one, the first time, if just it is the baseline and this is the level of antibodies produced, why is the level here not as high as here? If you put a baseline here, the second time you're producing so much more antibodies. So why is that? And the second question we can ask is, you can see this curve here, it is convex, whereas here is concave. So what makes this difference? The answer is all in this diagram. So the second time round, this is going to be, the antibodies are going to be produced this way, as well as the traditional pathway this way. So there'll be double the work. So the level of antibodies will be much, much higher. And also this way means it's faster, which is why if it's faster means the curve goes this way. This means it's slower, this means it's faster. So it's a faster and a higher rate of antibody response. So why do I need more than one dose of vaccine? Because as we've seen, number one, because more antibodies are produced, and number two, further maturation of antibodies occurs. So what do I mean by this? Try to look at these two diagrams here and see if you can spot the difference. Okay, so the difference lies in the key. This key has only 4 teeth, and this key has 5. This is the same lock. Okay, both are the same lock. The lock has 5 grooves, and they both actually fit very, very well into the lock. So they are all both very well fitted into the lock, but this one will be a much tighter fit. So this is an analogy. This analogy actually is trying to say that the first time you produce antibodies, you're going to produce antibodies that are going to be locking to the antigen. But the second time you produce the antibodies, they will actually mature a little bit more so that they are going to be really, really tight fit to the antigen. So they are going to be more effective. Further maturation of antibodies occur. Okay. Question. I still, if you can believe it or not, I still get patients asking me this. If I can build immunity myself after an infection, why should I even take the vaccine? So the answer is here. You can see, remember the time lag here. If just say you don't have any vaccination and you're exposed to the infection here, and if you have a very high viral load here, you will not have any antibodies until 4 or 5 days later. So your body cannot fight the virus. So there's a very high chance of getting complications at this point of time. So that's the danger of not getting vaccination. The second danger is if you are infected with just a mild number of viruses, you also produce minimal antibodies. It's not going to be as effective as getting a vaccine shot and then producing antibodies. And the third reason is our antibodies do get impaired in their production as we age. So if you're more than 60 years old, or if you have medical conditions that causes your immunity to be low, like you're not able to produce antibodies, so your antibody is going to be not enough. So this is a picture showing a kid, a teenager, young adult, and then elderly woman. And you can see the antibody production decreases with age. So that's why it's not wise to wait for an infection to get your antibodies up. Okay, so now the goal question, should everyone receive the booster? So this is currently still a debate that's going on even within the CDC and FDA. On one hand, there's a group that will say Why should we even need a booster? Because our current 2 doses are still very effective in protecting us against the coronavirus. And it's going to be a waste of resource. Instead of giving people the 3rd dose, why not use the vaccines that we have now and supply it to countries that don't have their 1st dose, or to kids and teenagers who have not been vaccinated yet? And then so they say that maybe the 3rd dose would just be right for high risk groups. And then the other group of people here, they have the opinion that it is always good to have more antibodies. So this is still an ongoing debate. Okay, experts appear divided. Okay, this is a New Straits Times article recently, September 19. So it says experts appear divided over the need for COVID-19 booster shots. Now, Dr. Thamasilan, he's the former president of the Malaysian Medical Association. So when asked about booster shots for the rest of the population, Dr. Thamasilan said that they too should be offered the 3rd dose after the groups who are at higher risk get their shots. However, this Prof. Dr. Sazali Abu Bakar, he disagrees. He disagrees and he says that we need a solid basis in deciding on why we need boosters and what are they exactly for. Do we have any data from the health ministry saying that the death rates among those who are vaccinated have been steadily increasing? And he also says that that Israel has reported waning immunity months after vaccination, which justified their move to implement booster shots. So he's saying that for Israel is different. They have given their population booster shots because they can demonstrate that there is waning immunity. So what is waning immunity? We will talk about that soon. Here's another article. Government agrees to implement COVID-19 vaccine booster shots. So in this article, our Prime Minister said that the priority for administration of the 3rd dose would be given to high-risk groups. High-risk groups refer to healthcare frontliners, people who are immunocompromised, the elderly with comorbidities. Notice it's not just elderly, it's elderly with comorbidities only. That means certain medical conditions, and those residing and working at long-term healthcare facilities. The 3rd COVID-19 vaccine will help increase immunity against the virus among people in high-risk groups, which may wane, that's that word again, which may wane with a certain period after receiving the 2nd shot of the vaccine. So what exactly is waning immunity? It's when an individual has built enough protection after vaccination, but then that protection decreases over time. So how can we measure waning immunity? Question, can we just depend on measurement of antibody levels? So the question is, we want to know whether our immune system has actually decreased in the protective levels, have decreased over time. And how can we measure that? Is it enough to just take our blood to measure antibody levels? The answer is no. And this is a two-way answer. I would say if you're on a personal level, you want to see whether your antibodies decrease, then yes, you can use the blood test to see your measure your level of antibody after your vaccination. But as a whole community, if you want to take the data, whether the community's immunity has reduced, we cannot just take the antibody level, because remember, it is not just represented by antibodies. Our adaptive immunity is also represented by this pathway here, the cytotoxic T cells, as well as the B cells, memory B cells, not just the antibody level. So it would not be accurate just to take blood levels and check if the community's immunity has come down. So we need to look at real world data, which means that we have to look at the number of infected individuals following 2nd dose of vaccination and look at the severity of the disease. Okay, so how much immunity has decreased and after how long? To answer this question, we are going to look at a study done in Israel. It was conducted at the end of July 2021, so not too long ago. And why Israel? Because Israel was the earliest to begin their vaccination program. So they are the earliest country, one of the earliest countries, so they can actually do the study, and the rest of us, in other parts of the country, in other parts of the world, can actually look at their study data. So this is the study that was done. Correlation of SARS-CoV-2 breakthrough infections to time from vaccine. So basically what this means is breakthrough infections means that you've already received your vaccination, But although you got your vaccination, you still get infected with COVID after that. So that if you got an infection after your vaccination, that is called a breakthrough infection. So this study, basically what they did is they took a number of people here, all of them have been vaccinated, and then they want to see how many people who have already gotten their vaccination still got infected with COVID. And out of those people, if they did get infected with COVID, how long did it take after the vaccination for them to get infected with COVID? So this is how they see and measure waning immunity. So this is the findings from the study. So what they did was they took 329,111 people. All of these people have completed their second dose. And out of that, they found that 1,911 people got breakthrough infection. So that is quite a good number because it's only 0.6% who tested positive. Whether symptomatic or not, 0.6% of that population tested positive. So which means that the two doses actually still work very well. However, out of that, out of the number of people who got infections, a huge number of them were actually earlier vaccinees, and only 760 were late vaccinees. So what does this mean? Okay, so this study was done end of July when Delta was dominant. And the way this study, they define earlier vaccinees is those who have been vaccinated between January and March 2021, which is 5 to 7 months before the study was done. Whereas late vaccinees are those who have been vaccinated April onwards. So, okay, so let's look at the conclusion. The conclusion number one is that, okay, so the whole conclusion is that what they found is that there's a 53% increased risk of getting infection in early vaccinees, okay, which demonstrates that waning level of protection occurs at least 5 months after the vaccine, after second dose. So to answer the last question, how much immunity has decreased? Only 0.6% of the population's immunity had waned, which means that the current 2 doses of vaccines still work very well to protect us against coronavirus. However, if immunity does wane in the 0.6%, when does it wane? The answer is 5 to 7 months after the second vaccination. Okay, so now the next and 22nd of August. Again, why Israel? Okay, can you guys hear me? I'm sorry. Can, right?
Yes, Dr. Adeline, yes.
Because they got in this. Okay, all right. So for that, let's look at another between. Okay, why Israel again? Because Israel has started giving their population a booster dose of Pfizer vaccine, so they can go ahead with their studies and give the data to the rest of the world. So this is the study. BNT162b2 refers to Pfizer vaccine. So Pfizer vaccine booster dose, a nationwide study in Israel, done in August. So this study, what they did is they took 1 million people, and all of them are 60 years and above, and they all got their second dose of vaccine 5 the study was done. Then they divided these people into 2 groups. One group was given the booster shot, and then they studied these people 12 days after this group got the vaccine. Because why 12 days? To account for incubation period. Because the whole purpose of this study is they want to see whether how many people has still got infection after getting the booster dose. So to account for the fact that some people, if they got infected with coronavirus on day 0, they will only show symptoms after 4 days, and some people only after 10 days, some people after 12 days, because the incubation period of coronavirus is that long. So they did it 12 days so that they don't miss anyone out. So the result of the study is this. In the group that only had 2 doses of vaccine, out of the 1 million, only 3,000 people actually treated infection, as opposed to if you got the booster dose, only 300 people got infection. So that's a big jump. 300 times 10 times 11 is 3,000. So that's about 10 to 11 times decreased risk of getting infection if you get the booster shot. So out of this study, I'll just do a simple conclusion. Number one, We can find, so the finding is number one, 12 days after booster, there is 11.5-fold decreased risk of contracting infection and a 10-fold decrease of severe infection. This one refers to this part here. So out of the 3,000 people who got infected here, only 300 of them had severe disease, meaning the huge majority of them only had mild to moderate disease. Same also here is about 10%. Okay, so here to here, there's also a 10-fold decrease of contracting severe infection if you are covered with the booster dose. Finding number two, out of the 1 million people, only 3,000 had infection. So that's still a good news, 0.3%. So it's about the same as the previous study. Previous study was 0.6%. So that's good. And also to note, at that time of the study, Delta was dominant, which means that we still have protection against Delta with the current two vaccines that we have. And also all these people in the study were aged 60 and above, which means they are the vulnerable group. So if they can be protected very well, what more? The younger population, they're definitely going to be much more, better protected as well. So hence, the current vaccines still work very well. Okay, finding number three, we can see here, right, that the vaccine protects us very well against severe infections. So have you ever thought how is that logical that, a vaccine cannot protect us as well from mild to moderate infection, but can protect us against severe infection? We always see that in many studies, this vaccine, that vaccine can protect us against hospitalization and death at a higher percentage compared to getting infection itself. So to answer that question, I'm going to zoom into this part and enlarge this part of the graph. And this is how it looks like. Okay, so just ignore this red line for a second and let's look at this. Just say this is day 0 and you're exposed to an infection, not just coronavirus infection, any infection. It can be dengue, it can be malaria, whatever it is. For the first few days, we're definitely going to have mild form of the infection. But as you have more and more of the organisms growing in your body, after 1 week or so, you're going to have a severe form of the disease, be it severe dengue, severe coronavirus, whatever it is, so severe COVID. So same here, mild, and then after 1 week, severe. So if you put back the graph of our antibody production, remember that after exposure to infection or antigen, there'll be a time lag. So you only start to produce antibodies after 4 to 5 days. So your antibody level protection or production is actually not as high when you're having the mild to moderate disease, whereas your antibody production is going to go high here. So it's going to cover the severe form of the infection. That's why it covers severe infection better than it does cover mild to moderate form of the disease. So that's an interesting thing to note now. All right, so next question, should everyone receive the booster dose? Okay, so the question, should everyone receive the booster dose, as I've asked before? The answer is, number one, it's not urgent, as the current 2-dose vaccination still confer good protection. And high-risk groups are encouraged to get the booster, as there is evidence of waning immunity after 5 to 7 months. So another goal question here, which vaccine should be taken as a booster? Okay, so before I answer this question, I'm going to say that I'm not an advocate for any brand of vaccine, but what I'm going to show you here is just information that is currently available out there from scientific research and clinical studies. And so I'm going to present you those data, and you can make your own informed decision and conclusion as to which booster dose vaccine you may want to go with. Okay, all right. Currently, there are no variant-specific vaccines that we already know. They're actually, like Pfizer is actually in the making for variant-specific vaccines, but it's not, it's not confirmed yet, basically. So what we want in a booster vaccine is something that can protect us against the current variant, which is Delta. So for that, we're going to look at this study done, published by the New England Journal of Medicine, the effectiveness of COVID-19 vaccines against the Delta variant. Okay. So the conclusion of the study, I didn't include the study, I just put the conclusion here, is that After 2 doses of Pfizer vaccine, you are 94% protected against Alpha and 88% protected against Delta. So that's quite good. After 2 doses of AZ vaccine, you're 75% protected against Alpha and 67% protected against Delta. So that's the data that we have so far. What about Sinovac effectiveness? Okay, so when it comes to Sinovac, there's really not much studies done. And if there are studies done, they are not really used to present data to the community or to the world, because the way they did their study is not very conclusive. They either have a problem of certain biases within their study, or that the population that they studied on is very small. So we can't really rely on data that they produce. However, there's this one rare study here done for Sinovac, and it's quite, you can say that we can take this data partially, and partially we can't. So I'll explain what do I mean with that. Okay, so this study is looking at the effectiveness of an inactivated SARS-CoV-2, essentially Sinovac, in Chile. Okay, so why is this study used? Is because Chile, majority of the population actually used Sinovac for their vaccination, their national immunization program. So which means it's covering a huge number of people. So that is going to be kind of a reliable pool to get a data from. So this study was conducted between February 2nd to early May, so means 3 months. And it was done on approximately 10 million people. So that's quite a huge population. And what they found is that the vaccine, Sinovac vaccine, is 66% effective against in protecting people from getting infected with COVID-19. But the downside to this study is that it was conducted at a time when Delta was not dominant. So we still need more clinical data to let us know about, whether Sinovac is going to be protective against Delta. Okay, so far, Sinovac effectiveness against COVID-19, it protects us by 66%. 87% protective against hospitalization, and 86% protective against COVID death. Okay, so what about mixing vaccines? Mixing vaccine means, it is also known as heterologous vaccination. And what this means is mixing different brands of vaccines. So what is our take on that? All right, although all the vaccines that we have now actually stimulate all the pathways of our adaptive immunity, the mRNA and viral vector vaccines, so AstraZeneca and Pfizer, they predominantly respond through T-cell mediated adaptive immunity response more than B-cell, whereas Sinovac works more on the B-cell mediated immunity. So it is probably going to be more, it's probably, and I'm going to use the word probably because there's no black and white evidence through clinical data. So I'm going to say probably. So it's probably going to be beneficial for us to mix Sinovac with AZ or Sinovac with Pfizer, because it may be exercising different parts of our adaptive immunity. But however, we still need the authorities to do more clinical data so that we can get confirmative black and white information on this matter. And also, if you remember, I was talking about the different parts of the virus, right? Remember that this is an inactivated whole cell virus. So we are introducing every part of the virus to our immune system. So in the sense that our immunity is going to produce antibodies towards the spike protein, towards the nucleocapsid, towards the envelope, so different parts of the virus. So we're going to have like not just land soldiers per se, but we're also going to have the Air Force, the Navy, so on and so forth. So it also may be probable at that sense that Sinovac is going to be a good booster dose. But we still need more data, and I'm not going to be saying that this is conclusive. Okay, we still need to wait for more data on this. However, data is available for Pfizer-AZ combination, and I'm going to show you that data. More studies are needed for Pfizer-Sinovac and Pfizer-Sinovac and AZ-Sinovac combination. So in this study, the researchers were looking at how safe and how effective. Immunogenicity means how much antibodies are produced. How much is produced when we compare heterologous and homologous prime boost schedule. Okay, so prime means the first dose of vaccination, boost means the second dose of vaccination. So which is good? Which is more effective? Is it heterologous, that means the two same brand, or sorry, two different brands, or homologous means two same brands? To put it in a more simple diagram, this is what it looks like. So what they did in this study, they had a bunch of people. They divide those people into 4 groups. And then this orange needle represents AstraZeneca vaccine. This yellow needle represents Pfizer vaccine. So the first group, the first day they had, the first dose was, they were given AZ, and then 28 days later, they were also given AZ. Second group, AZ first, and then Pfizer. Third group, Pfizer, and then AZ. And then the fourth group, AZ, and then AZ. And this is 28 days apart. So what did they find? This is the conclusion from the study. This group is the AZ group. This is the AZ Pfizer group. This is the Pfizer group. And this is the Pfizer AZ group. So they measured the anti-spike immunoglobulin. So this is the level of antibodies that was produced. And there's 1,000 units that was produced in this group, 12,000 here, 13,000 here, 7,000 here. So you can see there's a few things that you can see like here. It seems to be that if you've gotten the AZ dose as a first dose, it seems to be more beneficial to take the Pfizer as a second dose because the level is much higher. However, it doesn't seem to be the case here. If you give Pfizer, the level of antibodies that you produce is much higher than if you were given Pfizer then AZ. So you can draw your own conclusion from that. But the way that these researchers they conclude the study is like this. They said that it seems that heterologous vaccination either is AZ Pfizer and then Pfizer AZ. This heterologous combination is still better than this homologous vaccination. Okay, so it's 12,000, 7,000 is higher than just 1,000. So that's how they conclude the study, to show that there is flexibility in mixing the vaccines. So heterologous vaccines is beneficial. That's how they conclude this whole study, right? But how about the safety? When it comes to safety of mixing the vaccines, there is less severe side effects in the homologous group, the one that has two same brands of the vaccine, as compared to the heterologous group. So 2 different brands of vaccine seems to produce more intense side effect. However, this intense side effects is basically just like fever, muscle pain, tiredness, drowsiness, things like this. And they only last temporarily, only for the most 48 hours. So that's not so bad. There's also, they also saw that in this group that took the heterologous vaccines, there was a higher use of paracetamol. So that's just basically it. However, they concluded that the side effects are just temporary, so it's not going to be much of a problem. So my key messages here, my key message is, number 1, we are ultimately moving into COVID-19 endemicity. 2-dose vaccinations still confer protection to us. Currently, the priority for booster dose should be for high-risk groups that need an extra boost of immunity. As for the rest of the population, the booster shot is beneficial but not urgent. If you're going to take it, it's best to take the booster dose after 6 months after the second dose. That's a good gap to take. It is possible to mix vaccines. However, we still need more clinical data and findings, and there's a high possibility that the booster shots would be administered, the COVID-19 booster shots will be administered as regularly as the yearly influenza booster shots. So that's basically my key message. And I have 3 more slides here. What's new in vaccinology? This article in the Scientific American says, to beat COVID, we may need a good shot in the nose. Intranasal vaccines might stop the spread of coronavirus more effectively than needles in the arm. So what this article actually says is that, this is a picture of someone who has gotten the intranasal vaccine. So it's actually infused into the nose, as opposed to intramuscular vaccine, the one that we're getting shot into the muscles. So this intranasal vaccine, because you're introducing the antigen here, remember I told you about the innate immunity that lines the nasal mucosa? So they're going to make use of that innate immunity as well. They're going to stimulate production of more innate immunity cells as well as adaptive immunity cells. So it's going to be double the protection. And also, the other logic is that this is the first point of entry of the virus. So if we have a very good immune system here at our first line of defense, that's going to be more protective. That's what they're saying, and they're still researching on this. Than if we're just getting the intramuscular vaccine. So CanSino is a pharmaceutical factory in China. They are now developing inhaled vaccines. So it's now in the clinical trial phase. Or I think it's in the clinical trial phase now. But it contains lower amounts of antigen. Hence, we may need 2 doses. Intranasal vaccine is definitely going to be more tolerable because people are not going to have needle phobia and things like that. It's not going to be painful. It's just a little bit of discomfort. So this may be a suitable way to go for boosters if we will need it as regularly as every year. And with that, I thank you. Thank you for listening out to this whole long talk. I hope you guys understand what I'm talking about.
Thank you, Dr. Adeline.
Thank you, Doctor. Very good message.
Yeah,
Welcome.
I think my staff have question to ask just now. Philip, you have thing to ask, right?
Yeah, hold on, how do I?
Stop sharing. Yeah.
Okay.
Yeah, thank you, Dr. Adeline. I think
Right.
Philip and Mei Ling got question to ask, right?
It's in the chat, is it? No, okay.
No.
All right. Yeah, go ahead.
Adeline,
Yeah.
Dr. Adeline.
should we have a person go for test the level of antibody in our body after the vaccination? Is it advisable?
Is it advisable? So yeah, so if you're on a personal level, if you want to go and check whether after your COVID-19 vaccination you still have good amounts of antibody, yeah, you can go for it. There's no problem with that.
Because if you remember, our health minister once said, better don't go and check.
The reason he says that is because they're afraid that because there's 2 ways to interpret this. So I said, so on a personal level, yes, it's good. But if everyone is going to do antibody level and then they're going to collect data and say that most of us have decreased level of antibody after the vaccination, then people are going to mistranslate that and say that as a whole in the community we have waning immunity. Because like I said, when we get the vaccine, we also have to measure the cytotoxic T cell activity and then the memory B cell activity, and not only just the antibody activity. So it's not going to be a very comprehensive representation of our immunity as a community. That's all. But if you want to check on a personal level, basically the answer is, if you want to check on a personal level, it's all right. It's okay. Yeah.
You know, Malaysia, Israel information or Israel testing is not valid here, you know.
Yeah. Have you checked your antibody levels? You've checked?
No, I haven't. I was thinking, should I do it, you know?
Yeah, sure, no harm. So no harm in doing it. But give it some time. Give it some time. At least they actually say at least 14 days after your second vaccination. But I would say no, just take a bit more longer time. Like your antibody level, you can see the graph. It takes some time to actually go up. So maybe after 1 month will be a better time to check if you want to check your antibody level.
I see. Okay, maybe I will do it next month.
Okay.
Then the other thing I noticed your slide, there is an error in the. You put J&J and AZ under MNRA.
Oh yeah,
and the
right,
other
you're right.
viral one is.
Yeah, you're right. Sorry about
you
that.
just swap it back lah.
Oh, I'm so happy at least someone is looking at the slides and paying attention. That's good. Yeah, you're right. Okay, so yes, it's the other way around, correct?
Thanks.
Yeah, we are paying attention. How about other? Got any question? No.
Yeah, for me, no.
Okay. So really thank you
Can
for
I ask another question?
Oh, you have another question, Philip?
It looks like our boosters shot for normal people may not arrive until next year.
Yeah, it looks like that. Yeah.
And because I look at it is a commercial issue rather than a health issue.
Yeah, that's why I say I cannot really comment on the brand and all this whatsoever, the political part and all these things I cannot. But I want to do is I give you all the data. So when you all hear all these new vaccines coming out and all this new information about the booster dose, and now you understand what is T cell, what is B cell, what is heterologous vaccination. So you can make your own conclusion on that when the time comes.
By looking at your data, the hybrid version looks better protection.
Yeah, yeah, correct. Yes, yeah. But there's a difference as well. Pfizer, and AZ. I mean,
Which country have done this hybrid version?
UK has already done, and Chile also. Chile, because they found that actually for them, because Sinovac was the main vaccine in Chile, and then after some time they found that the effectiveness is not as high as they wanted. So they've started giving Pfizer to their as a second dose. So yeah, but like I said, it's very hard for me to commit to one brand. Let us wait for Sinovac and all these other brands to come up with better, data.
But the worrying thing is in Malaysia, every part of the world, there are still a lot of anti-vaxxer.
Yeah, it's very frustrating because that's why it's very hard to explain to them. But I think if they see this, this diagram of how our immunity works, that they have to understand there's a lag, there's a time delay before we produce our own antibody. So maybe if they understand that, then they'll understand the importance of the vaccines.
Correct.
I saw someone had a question.
Yeah, it's me. Okay, doctor.
Yeah,
Okay, I
hi.
just have one more question. Okay, let's say there's a mother, okay, still doing a breastfeeding, and they just got the vaccinations, right? Then
Okay.
is there any side effect that deliver the milk? The breastfeeding the babies. Any side effect for the babies?
Okay, don't have.
Eventually.
So don't have, because the reason being the vaccine components don't last more than 48 hours in our body. The vaccine, like for example, the lipid molecule that Pfizer uses and all that, and then the viral vector that AZ uses, once it delivers the information into our cells, they don't stay in the body more than 48 hours. And even if they do, these are not dangerous to the body. So yeah, to answer in short, no, there's no danger at all. Our production of antibody, actually, the mother produces antibody, is actually going to be protective for the baby as well. So yeah, it can spill over to the baby. So it's going to be good.
I see. Okay, thank you.
Welcome.
Hi, Doctor. Wai Kiong here from MSIG.
Hi, welcome.
You didn't touch on anything on ivermectin. Is it a good thing or a bad thing? It's still in discussion, right?
Yeah, but yeah, because my topic is not on ivermectin, it's about boosters. So
Yep.
ivermectin,
What's your take on that?
no, definitely not. So ivermectin, first of all, is a drug that is used to kill parasites like scabies, head lice, and then it's actually used more in animals to kill the worms that these animals, because they're eating soil and all that, so they get worm infestation. So we use ivermectin to kill the worms in their gut. So ivermectin, how it works is that it reduces the viral multiplication, right? So what they did is they did in vitro. So these researchers in the lab, they put some coronavirus vaccines into petri dish or some lab containers, and then they put ivermectin, and they found that ivermectin seems to reduce the virus from replicating. But it is different when you put it in a tube, and it's different if you're ingesting ivermectin. If you want to ingest and get the same effect as a tube, you would actually need much higher dose. It's not as simple, because in a dish there's no barrier, there's no like blood barrier, skin barrier, all these barriers before the drug gets to the vaccine, the virus. Whereas in the body, there's a lot of barriers. You have to ingest the tablet, it has to go through your stomach wall, go into your blood before it reaches the virus. So you actually need higher dose. And the dose that is and the dose, right, that is needed to kill the virus in the body is very toxic.
Kill the person.
Yeah.
Of course, the animals can take it better than humans.
Correct.
Yeah.
Yes.
Another question. How about what's your take on having kids taking the vaccines now? I understand there's Form 5, Form 4 onwards. I think some already got their first jab. And what about the younger ones? Like I have a daughter at 11.
Okay.
So she should be getting one next year, I hope.
Yeah. So last week, actually, Pfizer has announced that their vaccine is suitable for kids 5 and above. So they're going to start vaccinating them. They've actually done a clinical trial on 2,000 kids aged 5 to 11 years old, and they are giving 1/3 of the adult dose. So adult, you're having 330 micrograms of virus particles. For them, is 10 milligrams. And they've noted that the amount of antibodies produced is good and there's no side effects or very minimal side effects, as similar as the adult side effects of fever and all these things. So yeah, we may be also vaccinating them soon now in our country.
But the kids, as what you have put in your slides, they are actually having a higher dose of themselves having their own antibody. So
Yeah,
without a jab, they are still somewhat protected, right?
they actually have higher innate immunity rather than, okay, I understand. So you're talking about the production level. That refers to the production of antibody after you are introducing the antigen. So you still need to get them to be introduced to the vaccine, to the antigen through the vaccine for their body to be able to produce antibody. So without that, they cannot produce it themselves. If you want to wait for them to get infected by themselves, then get antibody, there's going to be a risk.
Yeah, understand.
Yeah,
Thank you.
welcome.
Okay, still got other question? If no, we will stop here. And we are thank you for Dr. Adeline provide this talk for us. Yeah, I found this is very useful, those of the data. And I hope you all also enjoy it and can share this with your friend and family. So we will end here. Thank you.
All right, thank you.
Give a
Stay
big
safe,
hand.
everyone.
Thanks, doctor.
Thank you,
You're
doctor.
welcome.
Thank you, doctor.
Bye-bye.
Take care,
Very good
everyone.
info. Thank
Take
you.
care, everyone.
Bye-bye.
Thank you, doctor.
Thanks.